going to go ahead and get started. I'm Sharon, one of the reference librarians here at the library. Thank you all for coming. We are very excited about the great lineup of presenters and programs that we have this year. And we're especially thrilled to have Dr. David Hutchings kick off our series for us. Before I introduce Dr. Hutchings, I've got a couple of announcements to make. There'll be a Q&A session at the end of his presentation, so please hold all of your questions until then. And wanted to remind you that our May 28th program is going to be How to Keep Your Brain Healthy and Decrease Risk for Alzheimer's Disease with Dr. Jeanette Norden, Professor Emerita in the Vanderbilt University School of Medicine. Our caregiver support group is also still meeting here in the library the second Friday of every month, and our next session will be Friday, May 10th. And please, everybody, enjoy some snacks, courtesy of the Alzheimer's Association. Dr. Hutchings is the founder of Dementia and Alzheimer's Care, LLC, a private practice firm focused on the evaluation, treatment, and clinical education of all forms of dementia. In 1921, he joined his practice with Blue Sky House Calls. Dr. Hutchings offers guidance to the Alzheimer's Association and also works with them and with the Alzheimer's Tennessee on state and national levels for clinical education to practitioners and caregivers. Dr. Hutchings specializes in geriatric neuropathology and dementias. He has a bachelor's degree from the University of Mississippi, a master's degree from the University of Central Missouri, and a doctorate from Nova Southeastern University. He's a nationally recognized lecturer whose clinical practice and research have led to keynote addresses at state and national organizations, as well as Duke, Vanderbilt, Northwestern, Auburn, and other universities. He's been published in clinical publications and peer-reviewed journals. In 2013, he developed clinical education articles on ALS for CNN, and in 2019 was featured for a month on News Channel 5 discussing Alzheimer's and dementia. He was named Columbia, Tennessee's Business Person of the Year in 2021 for his contributions to the community and healthcare during the COVID-19 pandemic. Dr. Hutchings serves as a faculty member at John Patrick University in the Department of Dementia, Alzheimer's Medical Program, as well as co-chair for the university's Cognitive and Memory Disorders. Please welcome Dr. David Hutchings.
Thank you. Appreciate it. I'm really surprised that they asked me to come back for a third year in a row, actually. I usually walk around when I speak and I'm kind of animated. My little clicker's not working. It actually works out for the best because last night we had a scrimmage game. My daughter plays softball and it was the parents versus the kids. I'm hurting. I'm just telling you, I'm hurting. But my daughter's really mad at me right now because I was playing shortstop and somebody hit a line drive and she was on second base and I caught it and I turned a double play on my own daughter. So I know she wouldn't talk to me this morning. So hopefully she'll get over it soon. But I felt bad. I turned around. I was like, oh no, it's my daughter. Well, thank y'all for coming out. So the topic for today's presentation is an overview, obviously, of dementia and Alzheimer's disease. And then they wanted me to talk about some more recent literature. So I'm going to put a little bit of a different spin on the literature because I think there's some things about dementia that I'm seeing every day in my practice that we just aren't really paying much attention to. Number one being early detection is absolutely critical. Before I came here just a little bit ago, I had a family member that was with me when I assessed a patient. And first they thought she was faking it. And then when I kind of explained everything, the light kind of went off to them and they're like, why did we not notice these things before? So when people are getting put on the memory medications, they typically do much better when they are early detected. So I want us to be looking for some things. I'm going to give some good tips on what to look for. We don't talk enough about nutrition in dementia, so I'm going to talk a little bit about that and how dementia affects nutrition and also how it affects how we eat and how we maintain our weight. And then I'm going to talk a little bit about staging and testing, and I'm going to try to get to the caregiver stuff as well. So let's jump on in. So if we look at, first of all, just a quick little overview. We have roughly 7,918 people every day turning 65. So this is what, and I'm a research junkie. I mean, I could be sitting on the beach and my wife's reading a novel and I'm reading journals, So what the research is referring to this is as the silver tsunami, right? Of all the people that are turning 65. So roughly 330 people per hour. But if we look at the baby boomer population, 10 million baby boomers are going to develop some form of dementia. That 71 seconds of a diagnosis of Alzheimer's disease is actually out of date now. So the recent research is actually around 35 to 37 seconds as we're seeing a diagnosis of Alzheimer's disease. And if you think about, that's an epidemic within itself, right? Because Alzheimer's is only one form of dementia. So that's the only the Alzheimer's stats. Now this is primarily where where my practice focuses in. I do private home assessments sometimes too, but mostly I'm in the assisted living, memory care, independent living facilities. And if we take the research out and look at that, almost 68% of patients in assisted living facilities have some form of dementia. And if we dissect out that 68%, you're looking at 34% of them have significant behavioral problems that are associated with dementia, okay? And when there's behavioral problems, that becomes an issue for everybody. And then also, the dreaded conversation of inpatient psychiatric care can come about. But a lot of times the behaviors are very easily fixed. They are. I had a lady this morning that I was being paged on over the weekend. She had a significant change, increased confusion, a lot of anger, a lot of sadness. And come to find out that her friend that she eats with every day has declined a little bit, and now she requires feeding. So that's what's caused her to have these issues. So really, when I look at the behavioral problems, I'm looking for patterns of the behavior, patterns of the sundowning. When are these things occurring to help us have a better idea of what to treat? And if we dissect this 60%, 68% out, of those patients, nearly 30% of them are more moderately severe. And this statistic here really jumped out to me. This was recently published, and $3 of the $5 that go to Medicare are going to pay for dementia patients in their care, which is just astronomical to think about that. So let's talk about early detection. I can't tell you how many times I've sat with families and they sit and you start to talk to them about all these symptoms, and all of a sudden they're like, gosh, now it makes so much more sense. This was going on 7 or 8 years ago. Why did we not ever pick up on this? And I'm going to tell you right now, I've never come across a family that ever were like, oh, that looks like dementia. So I always tell them, like, give yourself some grace here, because these symptoms are very, very, very subtle in most cases. And most patients are incredibly intelligent people where they can actually start to compensate and actually hide it. And we're going to get more into that when we get in the staging. But some of the things, and if you notice, I put memory loss on the bottom, and I did that for a reason, because dementia affects so much more than just memory. You think about your brain controls everything in your human body, right? And so we also do see a lot of personality changes. Some personality changes can be good, some of them can be bad. We also see a lot of impaired problem solving, and also very high level cognitive skills like balancing your checkbook, handling your money. These are things that we don't think much about, but those are very high level abilities, cognitive abilities. Getting mixed up on how to use a remote control or a phone or a computer, those types of things. And then we can have some behavioral problems. And I do want to emphasize that dementias are not a part of normal aging, okay? This is just not a part. We don't get older and we just don't develop some form of dementia. So dementia, actually, did y'all know dementia is an acronym? Okay, so when you're thinking about these things, and I remember a lecture I did a couple years ago for, it's called Home for the Holidays, and what to look for in your loved ones. And, when patients are repeating themselves and having short-term memory problems, those types of things, those are things to look for. But also, what I want you to come away with this is, when you go see your primary care doctor, go in there with questions and be an advocate for this person, okay? Because they're going to go in there and they're going to do a quick little test that's called the mini mental status exam. And Larry, that test has been around since, I think it came from the tree that Adam and Eve ate the apple off of. So, I mean, you really want to be descriptive and even talk to the physician prior to going in, saying these are the things that are going on. And I also suggest getting tested every 6 months. So every time you see your primary care doctor, being rescreened every 6 months to pick up on that early detection. But also realizing that, okay, maybe it's depression that's causing this. We've had patients that have depression can have very similar symptoms to Alzheimer's disease. I had a lady not too long ago that had a diagnosis of Alzheimer's disease, and when I went to go see her, she had some PTSD in her background and a lot of bad history, but she was taking so many pain medications. So I called the pain doctor. I said, "Is there any way we can trim some of this down?" And when we started to do that, guess what happened? She got a lot better. So the medications could have something to do with it. It certainly could be thyroid related and endocrine issues, vitamin B12 deficiencies, those types of things. It could be metabolic, epilepsy related, neoplasm or nutrition. It could be a toxicity or some type of trauma that the person has gone through. There could be some ischemic changes, and then also there could be some structural deficits or systemic deficits as well. So some of the things that we see, again, I highlight here, it's not a part of normal aging, okay? Frequent memory losses, or if we maybe have always cooked the same recipe and now we're having confusion doing that. Another thing I see a lot is an early detection is people mixing up their scheduling. And so if they have to have a doctor's appointment at 10 a.m., they'll get their scheduling mixed up. And again, that's that very high level cognitive stuff that we don't think about, but keeping up with those schedules can be very, very early symptoms for sure. Indecisiveness, difficulty handling money. If there's any difficulty with balancing the checkbook, writing checks for your power bill twice or 2 or 3 times, those can be an issue. But also paranoia around money. For a show of hands, has anybody gone through that where you see your loved ones have issues with paranoia with money, people are stealing, those types of things? So these are all very early things that, and it is somewhat normal. I mean, how many times have y'all walked into a room and forget why you walk in there, right? I mean, it happens all the time. But if we're repeating questions multiple times over and over, then more than likely something's going wrong. Keep in mind, by the time we start seeing these symptoms, that Alzheimer's gene is already mutated almost 15 years prior. So we have to start picking up on the symptoms early. And I'd rather you be more aggressive and be wrong and be tested every 6 months and be wrong about it, and it just be normal aging, okay? All right. So the 5 A's, I talk about this in every lecture, but I actually included this slide on the way over here today because I was assessing a patient, and I'm going to start with that one on the bottom called agnosia, okay? But I was assessing a patient earlier today. She is 58 years old, early onset Alzheimer's disease, and the family's there. And as I'm assessing, the family's in there, the daughters are in there, and I asked the patient, she was a real sweet lady, I said, "Who is that young lady sitting over in the corner?" And she just looked at her and she's like, "I don't know. I don't know who she is." And all of a sudden, of course, the daughter just broke out in tears and she leaves the room. That is an example of agnosia. And agnosia can raise its ugly head. We're going to get in the staging later and tie this in, but agnosia can raise its ugly head early on in the disease, or it can happen later on in the disease. And that's the inability for the patient to see a face and recognize that person and connect it to a memory or even an environment. Larry Dotson's probably one of the best ever to talk about how he dealt with his wife when Mary Ann was going through agnosia. But that's where we have difficulty recognize our home environment and also loved ones. And then we do have the amnesia. We do have memory loss. We have issues with that. If we have short-term memory loss and amnesia, we are going to have language problems, okay, because they sit fairly close to each other in the brain. And with the atrophy of the brain, what happens is that the patient, and I don't know how this would feel, but I see it a lot. I can't imagine knowing what I want to say, and I open up that filing cabinet and I just can't find the words. And that becomes very frustrating for patients when they can't communicate. So the aphasia is a big part of that. Apraxia is another piece of this. And this brings us to think, okay, dementia is much bigger than just memory issues. There's so many times I hear, well, she can remember everything from the past, but she can't remember any of the short-term stuff. And it's much more than that. And so apraxia is where the brain and the cell phone signal between the brain, the arms, the legs, the mouth is disrupted. So we can have walking problems, we can have eating problems, we can have swallowing problems, we can have a whole lot of other issues that occur with that. And if you ever want to learn what it feels like to what it feels like to have apraxia, just try writing a paragraph or your name with your non-dominant hand and figure out how much concentration that would take to write with your right or left hand that's your non-dominant. And then we have attention. This is one that comes to me all the time, especially around the holidays, is I'll get questions like, we want to take mom and we're going to bring her home for Christmas. And although their heart is in the right spot, and I can understand that, but if we bring mom home for Christmas, what's happening? We have kids, we have lights, we have music, there's meals, there's a lot going on there. And the brain cannot filter all that and block all that out. So what happens to mom? She wants to go home. She wants to leave. Her anxiety goes up. And so it may sound mean when I say, no, I would not recommend that at all. Maybe bring a small meal to the memory care facility or wherever she is and keep it very, very quiet. And that way the anxiety doesn't start to go up. All right. This is a great, do not ask me to pronounce this man's last name. I don't even know where to start. But this is, I'm going to call him William, okay? He was a fantastic painter. And in 1967, he actually drew a self-portrait of himself. He was diagnosed with Alzheimer's in 1995. And so he did another self-portrait. And a year later, you can see the distortions. And then by the time, we get to the year 2000, this is what it would look like for agnosia. So that's a great photo of not only how the vision changes, but also how that brain connects that to a previous memory. Okay, so with every dementia lecture, we have to go in the types of dementia. Okay, and I don't want to spend too much time on this because we only have so much time, and I want to make sure I do find time for questions. But these are your major types. Okay, now there are many other forms of dementia that are out there. There's alcohol-related dementias. There's Wernicke's-Korsakoff's. There's Huntington's chorea. There's a lot of other things out there that we see, but these are the most common. Alzheimer's tends to be one of the most common. I think it makes up a little bit over 70% of the types of dementia that we see. New research now has taken vascular dementia as the second and made it the third because Lewy body dementia now is the second most common form of dementia. And this past February, my wife lost her father to Lewy body. So I'll go into that here in just a little bit. And then we have the Parkinson's-related dementias, and then we have the frontal temporal lobe. And this one here on the bottom is what Bruce Willis has been diagnosed with, the primary progressive aphasia. So I'll talk a little bit about each one of these here. So Alzheimer's disease is not a genetic condition, okay? I hear this all the time is that, well, mom had the gene, my grandmother had, she had Alzheimer's, and, I'm probably going to get it. And should I get tested for the gene? And my suggestion is, well, no, because you can't change your genetics, right? But I would also be careful if you do get tested, like with 23andMe and places like that, because that could make your insurance premiums go up. I've been hearing more about that. But basically what happens in Alzheimer's disease is that being that it's not a genetic condition, your biggest risk factor is age. So by the time we reach the age of 80, whether we have a history of dementia in our family or not, the chances do go up to about 50%. But it still doesn't mean that you're going to get it. My grandma left Tennessee to go back to her farm on Saturday, and she's 102 years old, and she has no problems. And so, just because we have a gene does not necessarily mean that we're going to get it. But basically what happens in the pathology with Alzheimer's is that we've all heard of the plaques and the tangles, right? Would you like me to explain that a little bit and what all that kind of means? Okay, and I won't get too like nerdy on you, okay? So just kind of hang with me. So basically, neurons are, our twins just got cell phones at 13 years old. So if you think about neurons, they're like my twins on their cell phones. They just love to just chat back and forth. And so what happens is that there is a gene that's associated with Alzheimer's disease, and it's called the apolipoprotein number 4. And all that means is that gene is designed to go in there and clean out all the fats and the lipids in the brain. And when that gene begins to, when it mutates, now we have a buildup of fats and lipids in the brain. Well, they build up on those cell phones, on those neurons. So now we have this plaque on these neurons, and they no longer are able to communicate. And so they begin to draw or begin to have atrophy. But on that neuron, we also have over here, we have these little legs right here, okay? And I want you to think about this as a railroad track. And if you have a railroad track and you have two parallel bars and you have perpendicular bars, what would happen if you took away the perpendicular bars? There'd be no structure to that railroad track. It would begin to shift. And so that's what happens on the axon of the neuron, is that it does not have any structure. It's lost. It's what we call the tau protein. And so then it begins to shift and tangle. So we have the plaques and then the tangle, which causes the brain to essentially shrink or have atrophy or volume loss. So we see it on an MRI, it would say that we have cerebral atrophy or volume loss, and that's because of those plaques and tangles, okay? And this is where we do see it where it does affect short-term memory first, and then they have the long-term memory is later affected. But keep in mind, Alzheimer's, all the stuff that I was talking about on early detection, the problems with sequencing, the executive functioning, keeping up with the checkbook, the high-level cognitive skills, the repeating the questions, all these are going to be prime symptoms of what we see for Alzheimer's, okay? And there are different types of Alzheimer's. I don't want to get into all that, but there's early onset Alzheimer's disease, where we do see patients in their 50s and their 40s, and then we do have patients that are even in their late 30s, but that's a different gene, and those are more genetically related. So this was one thing I wanted to include here. I published an article a number of years ago on how to prevent dementia. And what was incredibly fascinating, this is up-to-date research, and where I started to get a lot of my research from on this was from the movie Still Alice. Have you all seen that movie? Okay, fantastic movie, but what's even better about it, the person that helped write that movie is a neuroscientist. And so when I started reading more of her research, it was quite fascinating because she was looking at the Alzheimer's gene, and I think I've mentioned this before, but she was looking at the Alzheimer's gene and she realized that that gene is the most prevalent in the Nigerian population, and the Nigerian population has some of the lowest prevalence of Alzheimer's disease. So then that's where it went down the research road to figure out why is this happening. Well, so number one, sleep hygiene is a big thing. We do recommend that you, we do recommend that you get at least 6 to 7 hours of deep sleep per night, all right? I don't always practice what I preach, but just hang with me here, okay? Diet has a big part of it. There's lots of great research indicating that more of a Mediterranean type diet is healthy, eating more fish, nuts, those types of things. My anniversary is tomorrow, and we're going to be going out for steak, so I guess I'm further not practicing what I'm preaching. And then making sure you're not having big meals before you go to bed at night, okay? Because remember, the plaques that get on those neurons, the brain has to digest everything. And so we need at least 4 hours for that to start to kind of go in there, and the janitors kind of go in there and start cleaning up some of that plaque. Everybody's doing physical exercise. That's a big thing, but everybody forgets about the cognitive exercise. Your brain is a lazy organ, okay? If I asked any of you in here in the next 6 months, I want you to be working on how to speak French and come back to here and talk to me in a French, dialogue for a little while. Your brain would be like, I'm not doing this, okay? It's very lazy, all right? But you do, and I'm not talking about word puzzles. I'm not talking about, finding words or crossword puzzles. These have not shown any proven research to actually help the improved memory or even ward off anything. I'm talking about learning a new cognitive skill. And people go to music instruments. I'm not asking you to be a concert pianist or a violinist, but learning something new that your brain is not used to doing. And that also would include increasing reading. If you're a reader, reading is very good because remember the language part and the loss of language and coming up with words. We need to exercise those language lobes. So cognitive exercise is a big part of that. And we did see a lot of people decline rapidly. I've done multiple lectures as how COVID related and how it impacted dementia patients. Because they weren't getting that cognitive exercise, and furthermore, they weren't socializing. Socializing is amazing for the brain. You're around people, you're using attention, you're using concentration, you're using social skills, and all those things are very, very important for it. Also, your mood. If we have a history of depression, that should be treated. Smoking, we should all know now that that's like really bad for you. So just stop, please. That includes vaping. I hope my brother sees this on video. He's like, oh, I quit smoking years ago. I was like, well, you vape. You still smoke. So all that stuff is bad. And then maintaining a healthy weight, and then obviously alcohol in moderation. So these 10 things here have been shown in the research to help prevent the onset of dementia, even with the gene. So vascular dementia, and then we're going to get into Lewy body. My stepfather had vascular dementia, and there'd be times I've been on the phone with him, and he'd be completely fine. You wouldn't think anything was wrong with him. And then you'd call him an hour later, and completely different person. Very, very fluctuating dementia. It's not the second most common form. Lewy body is. It does make up about 20% of the dementias, and this is where we see patients who have had a stroke history, where they have hypertension, they have uncontrolled blood pressure, they have cardiovascular disease, they have coronary artery disease, so they have a lot of cardiovascular histories. And when we look at the MRI, which I'll show you one here in a moment, you can see it on there where it's not so much atrophy. Well, there's atrophy, but you can clearly see the areas of the brain that are being insulted. So here that we do have, a lot of symptoms that we'd see in vascular. So you can see here these, and I'll show you on that side too. You can see these little white specks here. These are this is definitely a stroke, and then some of these are probably small strokes. But you see these big gaps in between here? That's the atrophy, that's the shrinking of the brain. And so being that there's vascular or ischemic changes all over the brain, this patient here is going to have a lot of movement issues. And sometimes what I see is that they almost look like a Parkinson's patient. They have a very shuffling gait. And so you can see over here, guys, that we have the gaps in between there, the atrophy, but then you can see these white specks that are not supposed to be there. This was probably a stroke for sure. Very, very fluctuating, and also a complete change in personality. That's another big part of that. Now, this does progress differently than what we would see for an Alzheimer's patient. Okay, so for Alzheimer's patient, we see a very kind of a downward sloping progression, where vascular is not like that. I want you to think of it like a stairwell. Like we can be good for a while, and then boom, we'll have a drop. We can have good for a while, and then bam, have a drop, and it's just very, 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 very fluctuating. And then, of course, we can have impaired cognition. If they have pseudobulbar effect, I have several patients with this right now, that it's just inappropriate laughing out loud, like hysterically, or even crying out loud for no reason. So we do see that. We do see the personality changes. We can see tremors and movement issues. We can see delusions and hallucinations. When it comes to hallucinations, the first thing you got to think about is, are they threatening in nature? That's the thing. Like, we don't always need to have the doctors come in here and start throwing medicines. If a patient is seeing their mom, I mean, I have a lady right now, yesterday she has lunch every day with her mom and her dad, and her parents, of course, have been deceased for quite some time. That's not at all, threatening at all. But if it is threatening, then we certainly need to address that. And then we do have coordination and balance issues, and we see incontinence come in pretty quickly when it comes to the vascular. So Parkinson's is really dementias. I remember when I was doing my clinicals, we were talking about Lewy body, and one of the neurologists came to me and he's like, Lewy body is that's just a textbook term. That's not even a real, that's just in textbooks. And now we had Robin Williams, and that brought light to Lewy body. And I cannot tell you how many times this dementia is misdiagnosed. And these dementias are really critical because if doctors treat these patients with certain medications, it can make the dementia worse, okay? And I know I've told this story before, but I want to tell it again. We experienced this firsthand with my father-in-law. He was in Kansas City, and he got diagnosed with Alzheimer's disease. And I told my wife, I say, this has all the earmarks of Lewy body. He's not sleeping at night. He has extreme hallucinations. He thinks that when he was staying at our house that it was a plantation home, and he was completely delusional. When he went into memory care, he thought that all the people actually worked for the government and they worked for him. Very pleasant man. But when he was in Kansas City, the doctor had put him on a medication called risperidone. And risperidone can make these patients worse. That's well documented. And so basically, he couldn't eat, use the bathroom, feed himself, nothing. Couldn't walk, couldn't talk, anything. So I had called the doctor and I told him, I said, you know, I feel like this could be Lewy body. And I said, we also had a psychiatrist look at him in Kansas City, and he agreed that, hey, this is Lewy body. And the primary care doctor snipped at me and he's like, well, I've been treating Alzheimer's for 25 years. And I said, well, you know, I don't know if that really makes you really good at it either, right? He never returned my calls after that. So we got him transported via ambulance from Kansas City down to Spring Hill. And within a week and a half, they discharged the medicine. And guess what? Eating, drinking, using the bathroom, walking, talking, doing all that. And he lived for another 3 years, which with a really good quality of life. But these dementias are very different, okay? So how it works is that if you have cognitive impairments, you have hallucinations, delusions, and definitely insomnia, and then you develop Parkinson's symptoms, that's a Lewy body dementia case, okay? If it's reversed and you have Parkinson's and then you develop the cognitive issues, then that's more Parkinson's with dementia. So the important part is when you're seeing that early detection and you're getting tested, make sure that you are going to the doctor, explain the symptoms, and making sure that we figure out what type of dementia that we're dealing with. Right? We say this all the time. If you had cancer, you'd want to know what type of cancer you have, what stage is it, and how the heck are we going to treat it? And we got to be asking our doctors those same things. Okay. Frontal temporals are fairly, I wouldn't say they're rare. I have right now about 42 different frontal temporal lobe dementia patients. They do start very young. And basically it is a deterioration of the frontal portion of the brain. So we can have a lot of, your first one there is your behavioral variant. That's where we have patients that completely lose their social filter. So I had a guy that was working for Amazon, and he ended up losing his job because he was saying things that were socially inappropriate, sexually inappropriate. He would look at somebody and say, well, you're way overweight, and say things that were just completely inappropriate because he didn't know that social filter was gone. And so you'll see that they'll have a lot of job issues because they're still young, they're still working. And a lot of challenging behaviors and impaired judgment. The semantic variant is a mix-up of language, all right? So where if we show you a picture of a Christmas tree versus a palm tree and said, okay, which one do you see at the beach? They wouldn't be able to differentiate those two. So the language is beginning to deteriorate there. And, you know, with Bruce Willis having primary progressive aphasia, I hate it, but what I do think it will benefit is that there will be more awareness of this condition. Primary progressive aphasia is very, very difficult to treat. And as I get into testing here a little bit, it's very challenging to test that type of dementia. Could you imagine knowing that you have a problem with your language? You can't understand what somebody is saying to you. You can't produce speech. You can't speak. But your memory is still fairly intact. So it's almost like you're in this prison in your head. So it is very, very difficult to treat. These type of dementias, if you see the life expectancy is around 6 to 8 years, so it is very, very aggressive. And these types of dementias are quite a bit more genetic or related too. Okay, so in frontal temporal, this is obviously a postmortem examination, but you can see all those gaps in the front. Back of the brain looks good, cerebellum looks good, some parietal stuff, but definitely you can see some atrophy here, and this is what it looked like for a frontal temporal lobe patient. Okay, so let's jump into some nutritional stuff here. What I've become, I look for most of my patients. Let me ask you this. How many people have ever heard the saying that pneumonia is an old man's best friend? Okay, a few, all right. So there are certain things that when it comes to dementia that we will see in every single type of dementia. Doesn't matter what type of the 86 that are out there, we'll see this. And this is where we start to have some issues with eating and swallowing. And I felt like this would be a big one, especially being in springtime. This is where we miss this the most. So essentially what happens is that if we look at a cross-section here, so we define it as dysphagia. A dysphagia just means that we have some form of a swallowing issue from the mouth to the stomach. When we learn how to swallow as a child, our throat reflex, our Adam's apple, it kind of develops first, and it's very quick. It moves up and it moves down. It has to move up to close off the airway. And when it moves up, it actually pushes the food or the liquid off into the esophagus. And if it doesn't move up, then that can actually get into your airway. How many people have ever swallowed down the wrong tube in here? All right, everybody. Okay, so I'm going to come back to that. So if we look, I'm sorry if I'm grossing y'all out with the cross-section cadaver things here, but so here's the mouth. This is the airway here. And so basically, once the tongue, if you can kind of think about the swallow as being, we have a mouth phase, we have a throat phase, and we have an esophageal phase. So once that the person starts to eat, when they're ready to swallow, they actually take that tongue and it moves front to back. So what happens with dementia patients when they're eating? They can chew and chew and chew or pocket food, and I'll show you that here in just a little bit. So basically, essentially, the swallow begins to reverse itself almost back to infancy. And then we have the impaired reflex. So anything that gets down in here is not good. So when that Adam's apple moves up, this little flap comes down and protects your airway, all right? So this is what it would look like to have in just a normal swallow that you do about 2,000 times a day. It's very quick, it's very coordinated, you don't think much about it. And you could see that the liquid that this guy's being given is being moved to the front to the back, and it shoots right down the throat. Now, what it would look like if we had a patient, this is a frontward view here, and you can see that the liquid just kind of shoots right down the throat, no problem whatsoever. Now, what it looks like if we have a problem in swallowing is what happens when you swallow down the wrong tube. You choke, you start coughing, right? What happens if you don't cough? Okay? Yeah. Yeah, it goes in your lungs. And what also happens when you cough? Yeah? Or your eyes are doing what? Your nose is watering? All right, so take the cough away from it. And all of a sudden, I'm looking at a patient, and they're just sitting there at lunch or whatever, they may have water next to the bed, and their nose is just pouring. And that's telling me, is like, okay, there could be an issue with the swallow here, which jumps the chance of aspiration pneumonia. And that's a very, very serious pneumonia. So the reason I brought this up in today is because we're in springtime, and so many times I hear, oh, this is just allergy related. And then all of a sudden you're like, well, wait a second, I don't think so, because this has happened every time a patient has intake. So if you're seeing that we're having some runny nose, watery eyes, my stepfather used to do this when he talked. It was a very gurgly type talk, so you could hear some of that liquid in his throat. These are big ones I'm always looking for. And anytime I round on a patient, I'm always looking for, are they maintaining weight and are they getting their hydration? Because those are two very big things. So, but this is a part of dementia that we can actually prevent, okay? But it happens with 100% of patients at some form in time. So if we look at what that going down the wrong tube looks like, that looks a lot different, right? So this is a patient with Alzheimer's disease with COPD, and you can see all that right there is going off into the lungs, and he tries to cough, but because of the COPD, he can't get that out. So you can see over here, we have that goes off in the lungs, he tries to cough and he can't get it out. So we have definitely a high chance of developing pneumonia there. And it's very treatable, but it does need to be identified or they will develop pneumonia. So this is the chewing. So if you can see here, there's the food stuck in the patient's mouth and we're just chewing and chewing and chewing. And eventually gravity takes a hold of it. And all of a sudden, this is the food. And this is the airway. This is the esophagus. And you can see that it just keeps moving down the throat. He didn't cough, he just kind of moved on me. And you can see it just kind of trickling off and it's just sitting there now. And so that's what it would look like for this prolonged, just chewing and chewing and chewing. So things that we definitely want to kind of keep an eye out for sure. Okay, so let's jump into staging here. These are the medications that we use to treat for memory. A lot of patients I'm hearing more and more and more that, hey, you know, our doctor, our neurologist put us on Aricept or Namenda, these types of things. They can work pretty well if, going back to my discussion of early detection, if we catch things early, those medications can somewhat be helpful. When they get to us and they're in the more moderate impairment, moderate severe impairment, I have not actually, because as I retest patients, I don't see that they're doing any improvement there. But you know, your Namenda tends to be one of the better ones. And there has been some clinical trials saying if patients are taken off of Namenda, we can see a decline. So, you know, that's something else we need to keep in mind. They're not hurting anything, but also they're not designed to slow down the progression of the disease. They're designed to help kind of improve the memory. So let me, we're at 42 minutes. How long do we need to go for? Oh, okay, so we have time. Okay, cool, awesome. But I also learned that the mind can only comprehend what your bottom can endure too. Okay, so I'm gonna keep that in mind. All right, so I don't wanna go too long and you're tired and your butt's hurting. And I just said that on camera too, apparently. So let's define what cognition is, because as we get into the staging here in a moment, you know, I want us to understand that, you know, as I said earlier, dementia is more than just memory. The brain controls everything. And I can sit here and tell you that by textbook definition, what dementia is, depending what textbook it is, right? But essentially, it's a decline of all mental and physical functions. But I had a lady early in my career, she looked at me and she said, I just don't feel like myself. And to me, I felt like that was probably one of the best definitions of dementia that I've ever heard. And so let's break this down in terms of what's happening in terms of cognition. So I'm going to define each one of these for you, but we do have immediate memory and short-term memory. They're different. There's long-term memory and remote memory are different. And then we have semantic and episodic. This stuff here, the executive functioning, is what I was alluding to earlier. That's your very high-level cognitive tasks, your ability to reason, okay? Your ability to multitask and very high-level cognitive skills. And then we talked about the aphasia and language pieces. So let's kind of define these for you. All right, so immediate or short-term memory, or immediate memory lasts up to about 10 seconds, all right? So if we're doing one of these quick little memory tests, let's say like the mini mental, okay? The doctor will give you 3 words to remember. I like giving 5, but because I like to make it a little bit harder. But whenever I start to test the short-term memory, as soon as I give the words, I grab my cell phone and hit the stopwatch. I want to know, like, where does this start to break down at? And so basically, a lot of times on those, especially on the mini mental, patients can score fairly high on that test, but still have pretty significant memory issues. So we have to be careful on which test is being given. I'll show you the ones that I give here in just a little bit that are a little bit more complex. So short-term memory goes from about 10 seconds up to about 20 minutes, okay? Long-term memory goes past that 20 minutes into maybe a few days or a few weeks. And then, did you have any pets growing up? All right, what was your names?
I had a watchdog named Timex.
All right, that's pretty cool. That's a pretty cool name. We have a cat named Orange. You know, so I'm not the kids named it. All right, and what town are you from?
Beaver Creek, Ohio.
Okay, cool. And what are your parents' names?
Bob and Phyllis.
Good. Where'd you go to grade school at?
Fairbrick Elementary.
Awesome. Name me two teachers you had in school.
Mrs. Adams and Mrs. Weishaupt.
That is remote memory. Those are things that are engraved, okay? So, you know, those are things that if we see remote memory starting to decline, then we know that we've had a significant decline in the illness, okay? What is 3 times 3?
9.
Okay, how do you know that?
I wish there ought to
Yeah. You know, nowadays, so they have the, you know, we learned off the index cards. Now my kids are coming home and you have to explain why it's 9. And I'm like, well, it is 9. It's always been 9. She's like, we have to explain. I was like, it just is. Okay. What happens if you touch a hot stove? You burn yourself. Those are facts. So semantic memory is memory from fact, things that we just know that are facts. Episodic memory. I have lectured here now, I think 3 times. Even though I'm a man, I'm not really good with directions, and I argue a lot with my lady on the GPS. I know how to get home. I live on Carter's Creek, and I know how to get to Carter's Creek from here because I've driven it a bunch. That's episodic memory. Okay, that's how we do things over and over, and we can complete those tasks. So transfer that over to like using the bathroom, showering, those types of things. If you go to make a pot of coffee, you have to have those sequences and those steps in perfect order. So this is not all areas of cognition, but kind of breaking down some of the things that we test. And then we had cause and effect in problem solving. So using good judgment, not, you know, knowing that we can't leave the stove on, those types of things that we have to look at. Cause and effect, divergent thinking. Let me ask, oscillating in the corner here. If you lock your keys in your car, so let's just say you go out in the parking lot and you lock your keys in your car, what are you going to do? Okay, panic? I mean like solutions. Yeah, right. If we hear somebody yelling in the parking lot panicking, that's what's happened. AAA, what if they don't pick up?
Try my husband.
There you go. Okay, that's divergent thinking. Okay, so we have a problem, and then we have to come up with multiple solutions for that problem. My wife called me and she told me she locked her keys in her vehicle. I'm like, that's okay. You know, there's a second set. She's like, yeah, they're in the glove department. And I was like, I don't know. Call OnStar. Hopefully they can unlock it. But that's an example of divergent thinking. But you have to sit there and think and prioritize and think, okay, what's the best solution here to solve that problem? And then sequencing is going to be a big one, okay? Going back to the conversation of early detection, we're having problems operating our cell phone. We have paid the same bill a couple times. I had heard this one last week. Well, I'll ask him to go out and do, you know, I'll give him 3 things to do, and he has so much trouble he can't do any of them. Well, it's because you have given him 3 separate things he's got to sequence through. These are very high-level cognitive tasks. And typically, these are the things that you're going to see, the change in personality, the very maybe mild word-finding issues, mild short-term memory problems, but more high-level cognitive stuff for your early detection, okay? And again, it's critical that we have that early detection. Okay, and then language. So, and I want to reiterate this, okay? When I'm with a patient, I am eye level with that patient at all times. I never stand over them because that's a sign of authority. Number two is that even if a patient is having extreme difficulty speaking, I had a lady a while ago that I said, I want you to name me as many animals that you could think of in 1 minute. She gave me 2 animals, and that's all that she could do. Okay, she had a hard time coming up with that language stuff. But if I said, Miss So-and-so, clap your hands 3 times and touch your nose, guess what? She could do that. So even though if we get to a severity where a patient is unable to communicate very well, do not think that they can't still understand you. And so even with the most severe patient, I'm actually talking to that patient more so than I am the family. Because I just think it's a matter of respect, number one, but also that patient can still somewhat understand. So I think it's very important to break these out. But again, remember, this is associated with short-term memory. If we're having language problems, then we're going to have short-term memory problems, but the understanding of language is still somewhat intact for quite some time. All right, so here's some cognitive tools here. I do have the Adam and Eve mini mental on there, but these are some of the ones. So this one is okay. It's called the SLUMS, the St. Louis University Mental Status Examination. If you go into your primary care doctor, I would ask either that the SLUMS is done or another test that we call the MOCA. And both of them are like 30-point little tests that you can do. It doesn't take very long for the nurse to come in there and do that, and to have that done every 6 months. I like the MOCA a little bit better because it divides out and looks at much more areas of cognition than what the SLUMS does. But I also like the SLUMS because it does calculate into the testing a person's educational level. So that's also good to know, like if they didn't go to high school or college, that's helpful. Yes, sir? It's not on there. I forgot to put it up there. Yeah, but it's... Yeah, right. Just think of it like a coffee drink, mocha. Yeah, it's like the Montreal cognitive testing test. MOCA, yep. And actually, you can download these tests online, guys, and you can even do them at home if you want to. I don't see any problem with that at all. I'm going to get into clock drawing tests in here in just a second, but I really want to spend a little bit more time on these. But again, I would try to stay away from this one. I do the mini mental status exam a lot for like court cases and things like that because the courts and attorneys still want to see those. But most of the time when I'm testing patients, I'll do a SLUMS and a MOCA, and they're quite a bit more descriptive. So, if you're suspecting, or even if you're reaching that age 80 and you're a little concerned about your memory, go in there and drive that care to your primary care doctor and say, I really want this cognitive test. I just want to check it and see how things are going. And that's it. We don't want to wait till it's too late and that's what happened with my father-in-law is we got behind the disease. And this is not a disease you want to get behind because we have got to be ahead of it. And that's where we get into the staging. So in the staging, what we look for is, how many of y'all heard of cognitive staging? Most of the patients, families that I'm associated with. So staging works that 0 is good and 7 is profound. And nothing irritates me more than when I see a report and it says dementia. So now I don't know what type of dementia I'm walking into. Or it says moderate. I'm like, well, what's moderate? So if I came to you and said, well, we have moderate dementia, and your question really is like, well, what's moderate? Like, what do I do next, right? So this goes into more detail. So 0 is good, 7's bad, and it goes down by the decimal point. So we could have a 2.2, we could have a 2.3, 2.4, we can kind of go all the way up to the 7 mark. But primarily what we're testing here is we're looking at a patient's ability to have concentration, all right? So if I was to, I keep picking on you because you're a sharp guy and you sat in the front. So, all right, name all the months of the year for me. January, February, March.
January, February, March, April, May, June, July, August, September, October, November, December.
Okay, cool. Name the months of the year backwards.
December, November, October, September, August, July, June, May, April, March, February,
January, boom. That's not, but you can ask a dementia patient, name the months forward, they can do it like that because you know what? That's not a cognitive skill, that's memorized. But you had to concentrate to do that. Good job, by the way, especially in front of people. That's pretty solid. I've been fumbling all over the place. So exactly. I'll ask you to do the alphabet backwards here in a minute. Okay, that's a little harder. So we do have to assess a concentration. Again, that's on a 0 to 7 scale. So then we test that. We look at the recent and immediate memory, okay? We test that 0 to 7. And then we look at the past memory. We look at where they went to school at. Tell me some of your friends' names and your children's names, those types of things. So we're looking at the past memory. Orientation, I had a guy a while ago that tells me it was 1998. Do I care? No, I really don't. But it does tell me that we have some more moderate, severe orientation problems. And then I'm looking at, can a patient bathe themselves? Can they toilet themselves? Can they pick out their own clothes? If we have somebody more high level, are they still driving? Have there been any loss on directions, difficulty finding new locations? If I have somebody that's still working, are they having any difficulty in their job, managing different things? So once we get all these, let's say each one of these, let's just say we have a 5 here, a 5 here, a 4 here, a 5 and a 5. You add all those numbers up, divide by 5, and that patient would be a 4.8 stage. And that's how we know where the stage is. Now, if we get into the more descriptive part of this, you can see that here's the severity levels. So once we get to 3, we have mild cognitive impairment. 4 is moderate. 5 is moderate to severe. And then we start getting into the severe and then the very severe areas. When we start to have language problems, remember the coming up with words and that kind of stuff, that's where you're going to start to see this kind of in the mild cognitive impairment range, and it's just going to progressively decline as we go through. The agnosia, not recognizing people, that starts to kind of raise its ugly head in the 5 range, okay? So we can start to kind of pinpoint. But what's pretty remarkable about dementia staging is, what if I have a patient that is a stage 4? And mild cognitive impairment is stage 3.0 to 3.9. When they start getting up into that upper 3s, we've run primary care has run labs. They have no thyroid problems. The MRIs have been done, and dementia is diagnosed. That stage 4 is by far the hardest, because patients are very well aware that there's a memory deficit there. And so there, what happens is depression comes into account. Patients will self-isolate. They'll try to compensate the best they can. And then you start to see a lot of issues there that you take a patient, if they were depressed or anxious before they got those impairments, and now we have them, it's just going to be exacerbated or get worse. And Larry, you define stage 4 better than I think I've ever heard. So I'm going to steal this from you. Is that it's the part of the brain that is intact that is battling with part of the brain that is deteriorated. And so that can be, have a lot of, again, a lot of anxiety and isolation and those types of things. But things change when we get to stage 5, okay? Because that's where we need 24/7 care. That's where, we are looking at more of a memory care environment, those types of things. So if I can go to a family and say, okay, we're a stage 4.2, and based on previous assessments, this is how it's progressed. So in the next 18 to 24 months, we're probably going to start thinking about memory care. So now I know where we are, how this is progressing, and then we can give the families an understanding of what is coming next here, and how can we say, okay, we have this much time to look for, this is what memory care we need, as opposed to, you go to the doctor's office and all of a sudden you get, they need to be in a nursing home, they need to be in memory care, and you're thinking, how am I going to deal with all this? So really trying to prepare for what's coming next. So that stage 5 does mean that we need 24-hour care assistance. And this is where patients are very unsafe to be in their home, unless we have the ability to where we can have caregivers in the home, nurses in the home to watch them, those types of things. But this is where we have moderate, severe cognitive impairment, and we have moderate dementia here. So this is where we start to have some issues. In stage 6 is where we start to have some of the swallowing stuff that comes about that we showed you earlier. This is where we start to have a lot more physical decline. inability to recognize loved ones, those types of things. We could have more delusional behavior. And then also we have, again, physical decline. The walking can be, the gait arrhythmia on how they walk changes, and just overall increased risk for falls and those types of things. And then, when we're at stage 7, we're kind of down in this area here. So it's basically, we start to kind of plateau at that point in time. Okay. Have any of y'all ever done the dementia virtual tour? Larry, I know you have. You have? Okay. What were your thoughts on that?
It was claustrophobic and kind of rattles you a little bit.
Yeah. Yeah.
Makes you realize how disturbing it is.
It is. And so basically on the virtual, Larry, of course, I know you've done it. What were your thoughts on it?
I just want to get out of there.
Yeah.
It's confusing, the lights, and just like you're kind of lost.
Yeah. And so when you go, and I would urge y'all to, if you can go through one of those, what they do is they put gloves on you, so it affects your sensory ability to touch. You have these headphones on you too, where you're hearing all kinds of horns and cars and people talking, and you can't pay attention. And then they also put glasses on you. We can only see no peripheral, but just kind of 2 pinholes in front. And so that's where, you think about the staging, we start to get into this stage 6, even late stage 5. That's a lot of what these people are kind of going through. So again, dementia, and after you go through that, dementia doesn't only impact memory, right? It affects all that stuff. So that's very important to look at. So does anybody know why we do a clock drawing test? And Larry, you can't answer. We don't care if you can draw a clock, okay? I'll just put that down. What we are looking at are areas on the clock for spacing. So you can see normal here. When patients are asked to, if they start to get the more mild cognitive impairment or even the moderate, you can see this is the time of 2:45. Though instead of going to the number 9, what they'll do is they'll either draw the 2 and they'll draw a line to the 5 and the 4, which happens very often. And then you can see here they start circling numbers, but you see the spacing of these numbers. Or what will happen even more commonly than that is when you give them a circle, they'll put all the numbers on one side. Okay, and so what recent research has shown us is that if we start having impairments in clock drawing tests, and I was really fascinated with this, is because it actually indicates a risk for falling, because the depth perception is off on their gait. So they, if they're switching from grass to a concrete surface or even walking upstairs, the depth perception is off with that. And on top of that, as we get older, loss of eyesight and having visual impairments are part of normal aging, right? So now we have this depth perception problem, and now we have visual issues. Then we have a risk of falling, and that's the thing we have to watch out for the most. I want to share with you a patient that I had. I was asked to fly out and take a look at her. She was in the state of West Virginia, very, very sweet family, and they couldn't quite figure out what was going on. Primary care couldn't figure out what was going on, and I was like, yeah, I'll come take a look at her. So I flew out, looked at her, and her clock drawing test was horrible. And she had a lot of short-term memory problems. But what was even more concerning is, going back to understanding the type of dementia that we have is absolutely critical, because she had an Alzheimer's diagnosis. So what we did is we had her walk, and if I'm walking right towards the camera, she would start to just kind of veer off. And so, significant fall history. So we did order an MRI, and it ended up being normal pressure hydrocephalus, where she had fluid, and they were able to do some stents and get the fluid out. So I want to show you a pre and post of this, of where she was prior to where she is now.
What am I doing?
Okay, I want you to draw a clock that shows the time 8:30.
I can't draw.
Well, just the best you can. Give yourself plenty of room.
Ain't got room for 11.
Squeeze it in there best you can.
See how the vision is so
Okay,
tight?
let it show 8:30.
I can't see my 8.
Just do the best you can there. All right.
And this
Thank you.
this is her mobility.
All right, Mom. Come to me.
And before I show this, watch where she starts on basically middle C on the piano, and you can see how
Alright,
far
Mom.
she deviates
Come to
off
me.
track.
Yeah. Yeah.
See how far we're coming off track?
I do, and then.
It's almost like she's walking in a boat.
Certain type of payment. I need to go out and get it seems like the.
All right.
Okay, so post-op,
Mom, I need you to draw me a clock. And we want to see the time 8:30. Draw it as big as you need to. Yeah. There you go. Put all the numbers on it. All right, now show me the time on the clock with a little hand and a big hand for 8:30. Make the clock say 8:30.
I know how to make 8 o'clock.
What does 8:30 look like on the clock? Just try your best. Great.
much different.
You did good.
And then she was walking like a marathon.
Good. Up and walk as fast as you can. Fast as you can. Increase your speed. As fast as you can.
How phenomenal is that?
As fast as you can. Fast as you can. Fast as you can. I'm gonna sit down.
So again, you know, here were somebody that was diagnosed with Alzheimer's. They couldn't figure it out, and you know, just by the motor symptoms, I knew something was not right. And then come to find out, she had normal pressure hydrocephalus. So it was treated, and last I heard, she's doing really well. So the takeaways here is, again, and we're going to open up the questions, okay, is that we have early detection is key, absolutely key. Be proactive and ask for those cognitive assessments, the slums, the mocha that I didn't have on there. You know, have them do those. And again, you can download them online. Try to give them to themselves. I mean, you do have to go through training to give those, but you can at least kind of go through some of those yourself to see if there's any memory issues there. Okay. Ask more questions from your doctor. Okay. Say, these are things I'm noticing. And other one too, make sure that you attend the doctor's appointment with your loved one. Okay. Because a lot of times they'll be like, oh, I want to go by myself, because they know something's going on, and they're in their Sunday best, they're on their top of the game, and they can trick. Because how long is the primary care doctor in there for? Very short amount of time, right? Or I'm testing somebody, I'm with them for an hour, maybe longer, you know, I can see things, you know, much more in depth. But be an advocate, okay? And it's better that you're an advocate and you're pushing for testing and nothing's wrong, okay? Because essentially that's what we want. If you feel like something's wrong and there's some short-term memory deficits, tell your primary care doctor, I want an MRI. Maybe see neurology. There are a couple good neurologists that are very good with dementia, okay? But when you do pick a neurologist, make sure that they have some background or some kind of specialty in the area of dementia. And I know a couple that I refer to quite a bit. Look for some of those other symptoms. You know, we can prevent pneumonia here. We can prevent the dehydration. We can prevent the malnutrition. And then always, again, if you can get a stage and then begin to track that, that's very, very critical. So find somebody that does cognitive testing that can give you a stage. Because the last thing you want is cortical atrophy. What was it, Larry? Cortical atrophy.
Cortical dementia consistent with a history of anxiety disorder.
Yeah, okay, yeah, that tells us nothing. So we need to know what type, we need to know what stage, and how in the heck are we going to treat this? And so we need to be asking those same questions, okay? So we had those 3. I think your mind can only comprehend what your bottom can endure, so I hope everybody stayed awake though, so that's good. So note that to the camera, everybody stayed awake.